Chiropractic care plus usual medical care for military personnel with low back pain. A new study focuses on low back pain in the military and compares usual medical care versus usual medical care plus chiropractic care. This study was led by investigators from the Palmer Center for Chiropractic Research in conjunction with the prestigious Rand Institute and Samueli Institute. It's the largest study of its kind. Specifically, what do we know about low back pain in this generally younger military population? Well, low back pain is one of the most common reasons to seek medical care and one of the most likely reasons for interruption of combat duty. Chiropractic care is available at 66 military health facilities worldwide. The title of the publication is Effective Usual Medical Care plus Chiropractic Care versus Usual Medical Care Alone on Pain and Disability Among U.S. Service Members with Low Back Pain, a Comparative Effectiveness Clinical Trial, published in the new JAMA Network Open in 2018. It was designed and conducted as a pragmatic comparative effectiveness clinical trial from September 2012 to February 2016 at 3 military sites: Walter Reed National Military Medical Center in Bethesda, Maryland, the Naval Medical Center in San Diego, California, and the Naval Hospital in Pensacola, Florida. Participants were either referred to the study by a physician that deals with spine pain or were self-referred through advertisement. An adaptive computer program allocated participants to balance assignment with regard to sex, age, low back pain duration, and worst pain intensity in the past 24 hours at baseline. Inclusion criteria were participants aged 18 to 50 years reporting low back pain. Exclusion criteria were low back pain of any duration from a non-musculoskeletal source, any contraindications to spinal manipulative therapy, recent spine fracture or surgery, or post-traumatic stress disorder. Interestingly, patients with suspected radiculopathy were included if it was determined no further diagnostic testing or referral to a specialist was necessary. So what was usual medical care in this study? Usual medical care included self-care, medications, physical therapy, and pain clinic referral. And for those that had usual medical care plus chiropractic care included spinal manipulative therapy of the low back and adjacent regions, and additional therapeutic procedures such as rehabilitative exercise, cryotherapy, superficial heat, and other manual therapies. There were 750 participants who were enrolled, 250 at each site. The mean participant age was around 30, which is clearly younger than the mean age of most low back pain studies. Also, there were 23% who were female and 32% who were non-white. There were many outcome measures. Primary outcomes were low back pain intensity rated with a numerical rating scale of 0 to 10, and disability scored with the Roland-Morris Disability Questionnaire, scores ranging from 0 to 24. Secondary outcomes included perceived improvement, satisfaction, and medication use. And additional secondary outcomes included worst low back pain intensity during the past 24 hours assessed using a numerical rating scale, and bothersomeness of low back pain symptoms in the past week, measured on a scale of 1, not at all bothersome, to 5, extremely bothersome. For medication use, participants were asked how often they took pain-relieving medication, both prescription and over-the-counter. Perceived low back pain improvement during the past week was rated compared to baseline on a 7-point scale, 0 indicating completely gone and 6 much worse. Satisfaction with care was assessed with a numerical rating scale, with scores ranging from 0, not at all satisfied, to 10, extremely satisfied. Now to the results. Adjusted mean differences in scores at week 6 were similar to week 12, and they were statistically significant in favor of usual medical care plus chiropractic care. We can see at 6 weeks that for low back pain intensity, the mean difference was a negative 1.1, for disability, a negative 2.2, for worst low back pain, a negative 1.2, symptom bothersomeness, negative 0.4, and for satisfaction, 2.5. And also adjusted odds ratios and risk ratios were calculated. We can see at week 6 that perceived improvement had an odds ratio of 0.18, global perceived improvement, an odds ratio of 0.18, low back pain intensity, a risk ratio of 1.43, and disability, a risk ratio of 1.35. For the use of pain meds, participants allocated to receive usual medical care with chiropractic care reported significantly less pain medication use than those receiving usual medical care alone, but not at any of the individual sites. As we will see, there are differences among facilities. This might be attributable to different management approaches. For example, we can see that the number of visits at each site varies. For example, for chiropractic visits, the mean number of visits was 4.7 at Walter Reed, 5.4 at Pensacola, and 2.3 at San Diego. The management approaches were different. Participants at Walter Reed were more likely to receive multiple ancillary therapies. Most participants in San Diego received therapeutic exercise for strength and flexibility. Usual medical care included physical therapy referrals and prescription medication with less variation across sites. The researchers state, quote, "The magnitude of mean between-group differences for both pain and disability are consistent with a moderate magnitude of effect as classified by the American College of Physicians and American Pain Society guidelines," unquote. Yet it might be argued that for the mean differences between groups, the differences for pain and disability barely reach a threshold for a clinically important difference. This is based on the moderate baseline level of pain improving in both groups, but with a mean difference of 1.1 in favor of the plus group, and the improvement in disability from a moderate level of approximately 10 to a mean difference of about 2.2 between groups in favor of the usual medical care plus chiropractic group. Although there may be some debate as to the clinically important differences in means for various outcomes, telling at 6 weeks is that 62.6% of patients in the group receiving usual medical care plus chiropractic care in the back-related function component had improved to a statistically significant and clinically meaningful amount, 30% improvement from baseline, compared to 46.6% of those in the usual medical group alone. So for improvement in function, the number needed to treat is approximately 6. In other words, the number of patients that need to be treated for one of them to benefit from the chiropractic plus usual medical care compared to the usual medical care only group is 6. And for pain, statistically significant and clinically meaningful improvement were also higher in the group receiving usual medical care plus chiropractic care compared with those receiving usual medical care alone at 6 weeks, the difference being 57.5% versus 32.5%. So for improvement in pain, the number needed to treat is approximately 4. In other words, the number of patients that need to be treated for one of them to benefit from the chiropractic plus usual medical care group compared to the usual medical care only group is 4. In an editorial to this study, Cherkin states, quote, "These findings are particularly noteworthy because it is usually more difficult to detect meaningful treatment benefits in patient populations who have especially promising natural histories, as they are young, physically fit, and unlikely to be using opioids, and include a large fraction of patients with acute pain," unquote. This study is well designed and executed. Yet there are quite a number of variables that make extrapolation difficult. As a pragmatic study, we have the advantage of seeing the effects of a chiropractic package of care similar to real-world variability. The disadvantage is that there is no standardized approach, so certainly among sites there is a large variation based on management choices. A factor which could be significant to the results and explain some differences is that patients had higher expectations of usual medical care with chiropractic care than usual medical care alone, as measured by the researchers. Yet, we don't know how chiropractic management would fare as a standalone instead of add-on approach, and we don't know to what degree any of the individual approaches were effective. In other words, is manipulation the driving force for improvement, or is it exercise, physiotherapy modalities, soft tissue therapies, etc.? Although there is both a statistical and minimally clinically important mean difference between groups, why is there not a greater mean difference, and why is it that At all sites and for most groups, the mean pain rating is still above a 2 3 months after care. We do know that these are more active individuals with more risk for re-injury and perhaps delay in healing, but do we know this is the reason why there isn't, on average, close to complete resolution? And because there is no control group for comparison of natural history and no long-term follow-up, it's unclear if this advantage is as strong as it appears or whether it is maintained. We know there are differences among sites. We can see, for example, that at the Pensacola site, the usual medical care plus chiropractic care group did show a significant difference compared to the other two sites for pain and disability. Pain was a mean of 1.7 at Pensacola compared to 3.2 at Walter Reed and 2.9 at San Diego. Why? Still, this study is important on several levels. The newsworthiness cannot be overstated given the publication in JAMA's new open access journal. The feasibility of large studies is now confirmed, at least in the military setting, and finally, reconfirmation of the safety and effectiveness of chiropractic management has been demonstrated once again.